Hello everyone. Today I am going to discuss about cellular or combined immunodeficiency. In my previous videos, I have already discussed that our immune system is divided into two parts, that is innate immunity and one is adaptive immunity. The adaptive immunity is also divided into two parts, that is active and passive immunity. The active immunity also discussed, and the active immunity also divided into two parts. One is cellular immunity and another is humoral immunity. The cellular immunity is mainly seen by the T cell and the humoral immunity is mainly seen by the B cell. In my previous video, I have already discussed about B cell immunodeficiencies. Now today we will discuss about T cell immunodeficiencies. So let's discuss. The first and the most severe type of immunodeficiency is SCID, that is severe combined immunodeficiency. What happens in skin? There is complete absence of T cell function and also B cell function. The main pathogenesis is the absence of T cell function. As we know, T cell function is required for B cell to produce some immunoglobulin, as I discussed in my earlier videos. So T cell having two function. One is the function for activating the B cell to produce plasma cell and immunoglobulin, and also the T cell having function to produce cytotoxicity, that means production of some inflammatory markers and kills the virus and bacteria. So if the T cell is having absence of function, so there is no B cell function is also hampered and there is no immunity present in the body. So the child is delivered with zero immunity. There are different types of SCID present and there is different types of mutation in the different genes, among which X-linked is the most common. SCID is the most common. That is X-linked mutation of the CD132 gene, which causing deficiency of interleukin 2 or gamma protein production. This interleukin 2 or gamma is mainly required for the activation of the T cell. That means the premature T cell went to maturity after this interleukin gamma 2 or receptors. So if there is a deficiency of this protein, then the T cell will be not matured and the patient is suffering from decreased T cell function. And there are also different types of SCID, among which autosomal recessive type of SCID is also common, that is RAG1, RAG2, ADA and JAK3 protein deficiency. In SCID, as I said, the T cell is not working properly and the function is also of the T cell is also decreased. So there is no tonsil and no lymph node is palpable or seen. So there is decreased T cell and no tonsil and no lymph node is seen. How do you differentiate SCID from X-linked agammaglobulinemia? In X-linked agammaglobulinemia, the B cell is decreased. In SCID, the T cell and B cell both are decreased. So if you do flow cytometry, then both the T cell and B cell marker are decreased in SCID, and in case of X-linked agammaglobulinemia, the T cell marker is only decreased. So there is increased chance of opportunistic infection. That means fungal infection, some viral infection, some cutaneous manifestation of Candida infection, or some respiratory sinus or sinus problem infection. Maybe child is suffering from this type of infections. The child is also suffering from if we give any live vaccine to the child may suffering from some life-threatening conditions. So in which there is a lymphocyte also deficient. The most common treatment is the most specific treatment is stem cell transplantation for SCID. Only case of ADA and X-linked SCID, the treatment of choice is gene therapy. These all are MCQs. So in SCID, there is complete absence of B cell and T cell function. The child is suffering from opportunistic infections from the birth, and the child will die within 8 to 12 months of life. There is no tonsil and no lymph node is palpable. Now Come to the second type, that is combined immunodeficiency. This is also one type of SCID, but in this there is not complete absence of T cell function, in which there is decreased or low T cell function. And as I said, T cell is required to function properly of the B cell. So as there is a T cell is function to some extent, so B cell is working normally and produce immunoglobulin. So in this case, the T cell function is decreased to some extent, but the B cell function is normal. The thermus is small or there is lymphopenia is seen, and the disease severity is depend upon the thymus size. If the thymus size is more, then the child is suffering from less immunodeficiency. If the thymus size is less, the child is suffering from more immunodeficiency. There is normal immunoglobulin, and opportunistic infection chance is high, but it is less than SCID. And the treatment of choice is stem cell transplantation. There is numerous different types of mutation causing this type of combined immunodeficiency. So how do you differentiate from this SCID to combined immunodeficiency? In SCID, the immunoglobulin profile, the B cell T cell is decreased, but in combined immunodeficiency, the immunoglobulin profile is normal, but the T cell is less, and the B cell also normally present. Now come to some syndrome like Dyer syndrome. As I say, thymus is the main media in which T cell is entered from the stem cell after producing T cell. So in the stem cell, the T cell is mainly from the progenitor cell. The T cell is enter into the thymus as a premature T cell, in which the T cell is going to proliferate and they going to mature. So if the thymus is not present in any patient, the child may suffering from T cell function defect, and the T cell will decrease in the body. In Dyer syndrome, what happens? There is a deletion of chromosome number 22q11 gene, in which as a result, there is a disruption of third and fourth branchial pouches formation. So, third and fourth branchial pouches mainly causing produce two things. One is the thymus, one is parathyroid, and also the face. So there is presence of there is absence or small amount of thymus is present, and there is hyperparathyroidism, and for which there is child is suffering from hypercalcemic tetany. And as the face is not fully produced, there is we can see bifid uvula, cleft palate and cleft lip can be seen, and the child is suffering from some cardiac problem like monotruncal anomaly or atrial anomalies or right aortic arch defect. Fish mouth faces is seen, and antimongular slant is also seen, and the child is having hyperthyroidism and posterior rotated ER. These all are MCQs. And this Dyer syndrome is the most common types of T cell disorder. So most common type of common immunodeficiency is Dyer syndrome, and the treatment of choice is stem cell transplantation. Now come to Wiskott-Aldrich syndrome. It is mainly X-linked recessive disorder in which there is a mutation of WASP gene. This WASP protein is mainly present in the T cell and also the platelet, and it is present in the cytoplasm of T cell platelet. So if the protein is deficient, then the platelet and also the T cell is decreased to some extent. We seen their triad, that is one is atopic dermatitis, recurrent infection, and thrombocytopenic purpura with bleeding. This is the triad of Wiskott-Aldrich syndrome. So we found if a patient having suffering from atopic dermatitis and the child is suffering from recurrent infection or purpura or bleeding from circumcision or bleeding diarrhea, recurrent bleeding diarrhea, then we think about Wiskott-Aldrich syndrome. In viscocerebellar syndrome, there is impaired response to polysaccharide bacteria. So, polysaccharide vaccine is contraindicated on viscocerebellar syndrome. In viscocerebellar syndrome, the platelet count is low and there is also low IgM, but the IgA and IgG is normal. And the treatment of choice is stem cell transplantation. Child is suffering from mainly polysaccharide bacteria. That means the child is suffering from staphylococcal infection, Haemophilus influenza infection, or any streptococcus infection. Now come to ataxia telangiectasia. It is a autosomal recessive disorder in which the ATM gene is mutated and the mutation seen in chromosome number 11q22. In ataxia telangiectasia, child is suffering from progressive ataxia, and this ataxia starts when the child is able to walk, and this is seen mainly at the age of 18 to 2 years, and the child is going to bedridden or comes to in wheelchair at the age of 10 to 12 years. There is presence of oculocutaneous telangiectasia at it start from age of 3, and the child is suffering from recurrent infection. In ataxia telangiectasia, the ATM gene is mutated and there is moderately depressed proliferation of T cell and B cell to mitogen is seen. That means if any antigen present into the body, then B cell and T cell will not proliferate as extent as that extent that the child is protect from this virus and bacteria by the immunoglobulin or the B cell. So there is a decreased amount of B cell and T cell production due to the gene defect, and there is serum IgA and IgG is less. These all are MCQs. Now come to hyper IgE syndrome. It is also a autosomal dominant disorder in which there is a mutation of STAT3 protein. This STAT3 gene is mainly a immunoregulator gene. It causing due to this mutation there is down regulation of production of some interleukins like interleukin 2, IFN gamma, interleukin 10 production, and the T cell is also decreased. So the T cell is not functioning properly and there is a decreased production of interleukins, and which causing decreasing the cytotoxicity of the cells, and the virus and bacteria will not killed by the body, and the child is mainly affected by staphylococcal infection, and the child is suffering from cold abscesses or recurrent multiple abscesses or pneumonia, and child is suffering from recurrent rheumatism or persistent rheumatism because there is a recurrent infection caused by pneumonia caused by staphylococcal infection. The second most common infection is fungal skin infection. So in hyper IgA syndrome, the child may suffering from recurrent pneumonia, recurrent fungal infection like candida. There is also some features from which we can suspect hyper IgA syndrome, that delayed tooth shedding, primary tooth shedding of the child, broad forehead, and broad nose nasal bridge. The diagnostic point is the high IgE more than 2000 is the diagnostic criteria, and there is absence of Th17 cell and the memory cell, and the treatment of choice is stem cell transplantation. So these all are the combined immunodeficiency or cellular immunodeficiency. In my next video, I will discuss about the phagocytic deficiencies.